Cytokine storm and role of Haemadsorption by Dr. Rajib Paul sir from Apollo Hospital. I would like to call upon Shrikant sir from AINU to please chair the session, as well as Dr. Dipti ma'am from ESI Hospital to please chair the session.
Cytokines and management of those problems. Sepsis remains an important cause of mortality in our patients, and the uncontrolled spiraling cytokines which create problems of their own are being dealt with by these extracorporeal methods. To speak on that is Dr. Rajib Paul. He is HOD Department of Internal Medicine and Chief Medical Intensivist at Apollo Hospitals, Hyderabad. He is past Secretary of ISCCM Hyderabad chapter. Sir, please.
Thank you, sir. It's a privilege to be part of a nephrology forum, not being a nephrologist. So just on the outset, I would say that I am into the extracorporeal device segment for the last 9 years, 2014, 9 years, and personally supervised and conducted more than nearly 750 of this extracorporeal devices. I mean, I should not say this, but one of the largest in the country right now. So I thought I have some experience to talk to a nephrology forum. Though not being a nephrologist, I may not be able to talk about the technical terms, which always I depend on my nephrologist. Dr. Sanjay is here, Dr. Ravi and the other team will be there. So if any circuit related problems, I obviously am not the correct person to ask those questions. But the device or what we are going to talk basically is nothing new. It has been since quite long time, more than 2 decades, that the concept of clearance of solutes which are toxic for the cells has been postulated and carried over all over the world in different modalities. And now with the newer definition of sepsis that has come, which has taken out the definition of sepsis from the organism to the host. Now sepsis definition basically is the host response. It is no more the bacteria. We are least concerned about bacteria. Obviously concerned about the bacteria, what antibiotic to be used. But the death of the patient is not only because of the bacteria what is hitting, it is ultimately the immune system or the immune function of the host. So it is now considered a dysregulated host infection response to infection. So the normal response to infection has got dysregulated, and that's caused the patient to go into sepsis and then septic shock, MODS, and ultimately some cases of up to 40% in case of MODS, septic shock die, and 20% overall sepsis mortality all over the world. Incidence of sepsis still remains and will remain much higher, or infections, I would not say sepsis as such. Infections per se will remain much higher than combined road traffic accidents or other conditions. So infections, especially staying in a third world country, we are surrounded by infections day in and day out, and I don't think any ICU in the country can tell that I don't have a patient with sepsis. And what we have learned in the last few years is the pathophysiology of sepsis, considering the infection as well as the tissue injury, both contributing to the patient. Whole concept was sepsis means infection, bacteria comes, bacteria hits the body, bacteria kills the body. Now bacteria kills the body in a particular way, in a sense that many patients will actually be fighting the bacteria or the infection, but the overwhelming response the patient has generated leads to organ injury. The organ injury leads to what is called as damage associated molecular patterns. They now start fueling the fire. So the fire was set up by the bacteria which came in. Now the organ dysfunction, it may be kidney, maybe a liver, and that has started its own cytokine storms, and that has ultimately leads to further amplification. So you kill the bacteria, but the patient died. So that's what the whole immune system, that immune modulation that we're talking of. And what has been also identified in the last few years is the concept of cytokine storm. There's no definition of cytokine storm as such. Cytokine storm basically is a concept in which the patient shows signs of hyperinflammation. It may be technically known by some parameters, or just look of the patient with the parameter the patient shows. A patient with a fever with a heart rate of 150, respirator of 40, who is hypoxic and who is producing less urine, probably a patient who is in cytokine storm. There's no number which you can say, okay, I do this test and say CRP is 200, 250, 400, procalcitonin is 20. That defines cytokine storm. So it's a concept. It is very well, we know it exists, and it is one of the causes, the cause of further worsening of patients. But there is no correct definition or correct way to know, oh, this patient will start cytokine storm has started. So, but the cytokine storm ultimately is understood to be the cause of the mortality, the morbidity, the multi-organ dysfunction syndrome, or the multi-organ failure, which leads to ultimately death of many patients. So the whole concept about immunomodulation or adjuvant therapy with filters, or what we're going to discuss today, is basically trying to mitigate the cytokine storm, to reduce hyperinflammation, to reduce organ damage. If reduce organ damage, less amount, your antibiotics are going to take care of the bacteria. Obviously, you have chosen the correct antibiotic. That's definitely the starting of the story. You have chosen the correct antibiotic, the patient died. So this is where in between, could we modulate the inflammation in a way so that the patient's hyperinflammation is modulated, and that leads to a better recovery of the patient. This is all which are being discussed in the last few years. We don't have randomized controlled trials except with polymyxin filters. Otherwise, it's more lot of data, case reports, prospective, retrospective data that we have gathered in the last 10 years or so. And all of us know about the capillary leak, vasodilation, and ultimately the MODS, which is the combination of capillary leak, vasodilation, and the ultimate disturbance of microcirculation. Once the disturbance of microcirculation is established, the survival of the patient is most of the times going to be poor. 2004 was one of the only publication which initial 20 years back was 2004, which had some discussion. Before this also people used plasma exchange, therapeutic plasma exchange, and but the main publication came in 2004 when Claudio Ronco and Bellomo basically published about coupled plasma filtration adsorption in patients with sepsis, a small number of patients, but that was the path-breaking article, or path-breaking, you can say, the study which ultimately led to more and more research on this area. They basically showed that using coupled plasma filtration adsorption, they could reduce the noradrenaline requirement or epinephrine requirement in patients with septic shock, and also improve the phagocytic effects of the neutrophils and the monocytes. So an immunomodulation, you could one side reduce the numbers of requirement or improve the blood pressure. At the same time also they could show the neutrophils or monocytes improve their phagocytic activity. There was an immunomodulation which happened. And subsequently lot of other things which have been discussed about CRRT, which we already are discussing today. CRRT is not a mode for right now, we all of know it is not a mode for, it does the clear cytokines, but it is not the ideal mode to clear cytokines. High volume hemofiltration, high cutoff membranes. High cutoff membranes have just come in the picture. We still don't have much data on that. Little difficult to use, but we don't have much data. I won't discuss on that. Polymyxin filters, which we all has been there for the last 10 years or so. The cytosorbents or the hemadsorption, CFPA, or which was the coupled plasma filtration and absorption, and also the auxiliaries. So we basically are dealing with now the three devices which basically we talk of the polymyxin filter, we talk of auxiliaries, we talk of cytosorb, and the fourth one which has come in the market is called the Zafran. I take the liberty of naming the companies because they have only one products with them. So that's why I'm naming the company, not the product as such. So, and the AADQI consensus basically said that in cases of sepsis-induced acute kidney injury, initiation of extracorporeal blood purification might be considered for immunomodulatory support in patients who meet explicit and timely clinical and biological criteria such as high concentration of DAMPs. Now we don't measure DAMPs, we measure cytokines. We measure IL-6. They are basically, one of the DAMPs that we measure is endotoxin. That is what one of the DAMPs that we measure. So DAMPs are damage associated, PAM, the DAMPs are the damage associated, not the so DAMPs we don't have a clear way to measure. It's a cytokine storm that we measure, that is IL-6, IL-10, and the TNF-alpha, those we measure, but there's no measurement of DAMPs. So it is some way summarizing that you get multiple parameters show that there is an organ injury which is driving the patient's worsening. In such cases, PAMs and DAMPs, if we can do it, for the PAMs it's not very difficult, endotoxin assay is there. So in such cases, you could use immunomodulation in the form of extracorporeal blood purification. And the same guidelines, the 2018 guideline also said that it could be a standalone therapy. You don't need a patient to have acute kidney injury for starting extracorporeal devices for blood purification. So if the patient does not have AKI, does not mean that I can't use the filter. It could be a standalone. If the patient shows signs of hyperinflammation, the patient deteriorating, maybe oliguria or may not be fitting the criteria of AKI as yet, but patient can be started even there is evidence of hyperinflammation, and when sepsis is the diagnosis, or even non-infective conditions, example is acute severe pancreatitis. there the patient could have polytrauma burns. These are the non-infected conditions where there could be still hyperinflammation, and before the patient can go into kidney injury, you could still use such devices. And the same guideline also said that it is important that the center should be trained in using such devices. So they have to access vascular line placement. Obviously, this is important for any extracorporeal device. Trained technician to or trained doctor to put proper lines, maintenance of lines, maintenance circuit. So that then they just added to that you need a proper setup to use such devices. And what we are discussing mostly about adsorption today. The filtration and the adsorption is what the polymyxin filter, the cytosol filter, and the Zaffron that were basically are based on this, and even the auxiliaries based on the absorptive. The auxiliaries also has a convective property, but the major thing is adsorption. So adsorption is based on basically the blood flowing. It's something like a hemoperfusion, where the blood flows through a filter, and the blood flows through microbeads or a porous sponge type material, and the hydrophobic molecules, the middle molecules, which we call as 10 to 60 kilodaltons, or some ionic charged molecules can get absorbed. So that is the whole concept of heme adsorption. So absorbing the middle molecules, which actually covers most of the cytokines. Volume hemofiltration, basically all of you nephrologists, you know about it, is a continuous hemofiltration at rate of 50 to 70 ml per kg per hour for 24 hours. Or some people even started pulse VHF, which was at 100 to 120 ml per kg per hour for 4 to 8 hours. This was basically has been practiced for many centers. But however, till now it has shown contracted results with no improvement in mortality or hemodynamic variables in few randomized trials that were there. And the problem with high volume hemofiltration was the loss of small molecules, vitamins, nutrients, antibiotics, and there is no way to actually measure how much antibiotic dosing, all that we discussed here. Again, the high volume filtration lots and lots of minerals, micronutrients, and will happen, which can actually cause further duration of the patient. So it is other downsides. It is center dependent. Every center can't do an HVHF, and you need trained technicians. Obviously, as hypophosphatemia, as Madam was talking about, is a major complication of this type of, and we have to be continuously monitoring phosphates. High volumes, blood volumes have to be required. And 2000 renal study, there was no benefit in the effluent flow rates, 25 versus 50. So this was the first study which compared 25 ml per kg flow versus 40 ml per kg. They did not find any difference. So that was the first study which showed that high volume hemofiltration did not improve outcomes. It was followed up by 2000 study, the EVOR study, which again showed that there's no much benefit of high volume infiltration. Probably the benefit did not happen because it moved out many other things which were not required, should not have been done. So it did its work. It is not that high HVHF does not work. It removed the cytokines, it removed the toxins, but it also removed so many other things which may have actually saved the patient. Probably that is where the problem lied, and maybe further modification of that may help us to get a better outcomes in the future with this. And other adsorption techniques we are discussing as we are discussing now. So these are the three the adsorption devices, where the first one is this is all of us know about the todamyxin or the Tode filter, first adsorption device which was widely used all over the world, the polymyxin filters, in which basically it is nothing but a polymyxin coated filter which binds LPS. And the other is cytosol, which contains microbeads through which blood filters, and the microbeads absorb hydrophobic molecules in the middle molecular range. And third is the Zaffron, which has been recently launched from the Chinese companies. And they also have a porous sponge-like material, macropolymer they call it, which again absorbs cytokines. So this is the three one which we have in the market. The new one, Seraph, which is cytosorbent, we are not discussing that because I don't have much experience of that also. So coming to, So important when you are doing hemadsorption, it's important to know which device has a higher surface area. This is not a convection, this is a adsorption. So obviously by common idea, better the absorption means you need a better area, higher the area. So device selection will be based on your area size. So talk to the company guys, get to the literature, which of the devices have the highest areas. That is one of the ways where you could use the devices. No point in selecting a device which is a very low surface area. Adsorption is going to fail there. So that is one of the things which you should know about hemadsorption devices when you're talking of filtration of cytotoxins. And as per the literature, all of this actually remove the Tode filter, Cytosorb and the Jaffran both will remove the middle molecules, which I was discussing about, in the range of 10 to 60 kilodaltons. So this most of these cytokines will fall in this subgroup. Also important to know about other things like blood flow range, like Cytosorb can be used wide blood flow range from 100 ml per minute, to even 600, 700 ml per minute. Preparation time is very important when you're talking of technicians. How easy is to prepare, how much priming and all this, in which Cytosorb scores here is one of the easiest one to prepare. You just need any basic technician can just prime the circuit and start within 15 minutes. Most of the other ones require more longer, 45 minutes to 1 hour of preparation or priming time. And maximum use time per cartridge. Here there is some, regarding the auxiliaries, it's not clear how long it actually starts as a cytokine filter along with a hemofilter, and subsequently we use it as a hemodialyzer, so which can continue like a CRT machine, CRT dialyzer for 72 hours also, as we were discussing just now. So we are not very clear on the auxiliaries how long we can use as a cytokine filter. We know it can be used as a CRT filter much longer duration. So all these important questions which you have to ask. Is my patient having an AKI? Does the patient require a CRT? If the patient requires CRT, how long the CRT I'm expecting? Or if the patient is completely anuric, how is the blood pressures? All this will lead to which device may be chosen at this different time. So Cytosorb is presently the unique solution in that it is presently was initially recommended 24 hours, now it's come down to 16 hours, and some cases even 12 hours the device can be used. Higher flow rate, easy to set up, and can be used with multiple platforms. You just need a blood pump, nothing else. A basic blood pump, and you can use the Cytosorb device. And also as a proven safety, does not remove important molecules like albumin. It has a concentration dependent, that's an important mechanism of working of this. Higher concentration of cytokines, it will remove cytokines. When the concentration comes down, its absorptive capacity comes down. So concentration dependent, very important, so that it does not wash out everything. We don't want to completely wash out of every cytokine. And no activation of the coagulation and the complement system. But most important, early intervention is the key. There's no point in discussing hemadsorption therapy or adjuvant therapy when the patient is on the deathbed with 3 vasopressors, CRRT machine, patient on a ventilator, and you are just somehow trying to maintain the blood pressure, DICS setting, and now you come, okay, let me start a filter and see something. It's not. That is already the end of the story. The patient is already left us. We're just trying to salvage some, a few days for the patient or a few hours for the patient. So there are a lot of clinical data which has come in the last few years. Till now we don't have a randomized trial, controlled trial on Cytosorb as yet. But the trial which has just been started is the process trial, which should be available in the next 4 years, the results. And this was a few other case studies or the case reports on Cytosorb with, this was Kogelman and his team. 26 consecutive patients of septic shock and Apache score of more than 25. Apache score of 25 by default correlates with a mortality of 55 to 60%. And all of these patients required had AKI and required CRRT. So 13 patients of abdominal and 13 patients of pneumonic, and this he showed that early starting improved outcome. This was publication 2014, I believe, 15, I think, yeah. So, and again, to another publication from Fritzke et al., and again 20 consecutive patients with refractory septic shock with high lactate and high noradrenaline requirement. With in this patient group, they mentioned they monitored IL-6, which was more than 1,000. Nowadays our cutoff is around 500, which we use IL-6 for using such devices. And they showed this was a study for not for mortality, basically vasopressor requirement or lactate clearance. Both were achieved in this subgroup of patients by using of devices. And shock reversal in this subgroup have happened more 65% patient actually achieved shock reversal. Not only the noradrenaline requirement came down, shock reversal happened in near 2/3 of the patients. This is another study with this was retrospective investigation initial study in the patient with CRRT and Cytosorb, 67 patients, but CRRT alone 49 patients, and matched propensity was done in this group, and they found expected mortality of 75%. With after using Cytosorb, the mortality came down to 48%. Looks little much, so there was a lot of people felt a lot of bias in the matching in this because the mortality difference looked so much, but actually very small numbers. So in such small numbers, you really cannot estimate the data correctly. And this was again another study which showed reduced vasopressor needs and restoration of hemodynamic stability. Again, a retrospective study in 42 septic shock patients with the CRRT and cytosol versus 42 matched controls. This was a time period study, 2015-2019 for the cytosol group and 2011 to 19 for the only CRRT group. So it is a retrospective study. So going back the data and seeing how many patients required cytosol, how many required say cytosol with CRRT, how many only CRRT, and then matching the patients to try to achieve some data. And ultimately it was shown that, like the Frisk study, there was significant reduction in the vasopressor requirement in the patients who achieved got cytosol with CRRT. And also when they extrapolated data, it found improved mortality also at 28 days. So I'll skip few of the slides. Yeah. Also recently in the publication of 7 consecutive patients of this cytosol mortality with CRRT and ECMO, very small number, but all these 7 patients with a very high Apache score, 39 Apache, 39 would mortality, you're talking of somewhere 85 to 90%. Observed mortality in this group of CRRT, cytosol and ECMO was for 43%, expected mortality was 90%. So very small numbers, but signals. We're looking at signals. We're not looking at data as a composite data, we're looking at signals. Yes, it could be used in dire situations also. And this is more of a data which showed that blood from septic patients were incubated with the umbilical vein, and they showed that this was basically showing that using cytosol device can improve capillary leak. So this is lab testing, you could say. The umbilical vein from septic shock patients was incubated with plasma from a septic shock patient, and another sub patient who actually received cytosol, and septic shock received. So the plasma from the cytosol treated patient did not cause any capillary dilatation, while the other one, non-cytosol plasma, did cause capillary dilatation. This is a lab study, just quoted it for reference. So immunomodulation is what we are discussing. So a lot of discussion has happened to that in the last few years, that okay, I am removing cytokines. Does it mean that all the good things also go out? Obviously I am taking out the bad things. So the criticism is, you take out bad things, good things also, how do you control the good things? So that's a question. Yes, all of us agree that is very possible. You no way that you can filter out only good bad things and keep the good things as well. That's very much tailored. We maybe 20 years later we may have such things. But this is a small study which showed that bad things are not taken out so much. This is basically done in healthy volunteers. 12 healthy volunteers who received, basically 24 volunteers, 12 group who received lipopolysaccharide injection, the LPS injections. Think of these volunteers, they got LPS injections, and immediately 12 of them underwent cytosol within 20 minutes started, and the others 12 did not get cytosol. Routinely the treatment was given. In this subgroup, they found that initial, you could see the TNF alpha, which rose in the patients, was mitigated by the this was the red ones are the patients who did not receive cytosol, while the blue ones are the ones who received cytosol. So the patients who received cytosol, the TNF alpha, the IL-6, the IL-8, and the anti-inflammatory IL-10 all were high, and obviously the blue ones are the cytosol, they were much lower. What was important is the same people, the 12 to 24 people, got another LPS injection after 7 days to see what happens to the immunomodulation. Second time it was also shown that the markers rose and there was a mitigation, but there was no absolute immunosuppression. This was the data from a few small but healthy volunteers. So how healthy volunteers we can corroborate with sick patient, we don't know, but this healthy volunteer data, it does not cause excessive immunosuppression. And our experience in our cytosol, I told you I have a lot of experience, but one of the few published studies where this was again a prospective multi-center. This was not a randomized control, obviously in investigator-initiated study. We had 4 centers, basically we had Apollo Hospital Hyderabad, Apollo Hospital Chennai, Ruby Hall Pune, and the Nayan Hospital, Nayan Institute of Cardiac Sciences in Bangalore. All of us, we basically used, this was in 2018, 16 to 18, and we looked at these various parameters of vasopressor requirements, IL-6 levels, organ function, survival outcomes, length of treatment, and safety. And we saw that there was with patients who received cytosol, there was a reduction, though non-significant reduction of vasopressor requirement. Apache scores, SOFA scores, and also IL-6 measurement is only parameter that we, only the cytokine that we measured. There was a reduction in the IL-6 group. That is what is the filter supposed to do. Post-therapy, 26 patients survived, and with the requirement of vasopressin levels and all coming down, coming down. IL-6 reduced by 50% and Apache scores were reduced. So in the conclusion, it was that our study which showed hemodynamic stability, organ function, reduction in IL-6 levels. It was at 2018 we basically published as might be an effective adjuvant therapy and could be used till further more and more data needs to be got, and it should be used preferably in the first 24 hours. Few of my other publications in snake bite, in urosepsis, and patients with CKD with septic shock. Few of the other publication, and few more also we have. The present Indian perspective, we have also been a part of it. So basically, when we are diagnosing septic shocks, use standard therapy. First 6 hours, there is no discussion of cytosol. Use standard therapy. Your fluids, your antibiotics, vasopressors, whatever. After 6 hours, your standard of care, you look at the patient, and then you see whether the patient noradrenaline requirement is increasing. We have set a number as 0.3 or more, but that's based on the whatever data we have from all over the world. But rising noradrenaline requirements, rising lactate levels. We do lactate at 0 and 6 hours, part of the sepsis protocol. Rising lactate level. You have got a procalcin report by the time the PCT has come, it is high. And also, if you have IL-6 in your center, IL-6 of more than 500. If your patient has evidence of clinical hyperinflammation, and then you have these parameters, at end of 6 hours, high requirement, increasing noradrenaline, increasing lactates, and IL-6 on the higher side, procalcitonin on the higher side, probably this is the candidate patient who would benefit from the device. So you would use cytosop in such patients or filtration. And then how to continue or stop it. And again, after 6 hours of using the device, 6 to 12 hours, evaluate the patient. If there is clinical improvement significant, shock reversal or shock or have vasopressor requirement come down by 50%, that you achieved your target, or and you stop the device. If partial risk recovery has happened or partial improvement has happened, then you continue second device after 6 to 12 hours, some cases 16 hours. If the patient has worsened in the 6 hours of your using cytosop, obviously there is no point in continuing a second device. And the cytoscore, this has been developed by Kogelman and team, and we are also developing a cytoscore in our country to our Indian perspective. This score is a rough score for the intensivist, junior intensivist, or the guys in the ICU. Simple score to calculate based on this, a score of 6, more than 6, puts the patient in a hyperinflammatory state and probably will benefit with immunomodulation therapy. A simple score, anyone can do the scoring in the ICU. This is called the cytoscore right now. This was our review paper, which myself and Dr. Yatin from Delhi, then Dr. Rabbani from Bangladesh, Dr. Acharya from Nepal, and Dr. Vitaranacharyari from Sri Lanka. We wanted to do a Southeast Asian perspective in our neighboring countries. What is the state of sepsis and septic shock? And ultimately found that even countries, resource poor countries, like we'd consider Bangladesh, Sri Lanka, relatively resource poor compared to us, there is more acceptance of devices, and more and people are understanding the use of these devices. So we wanted to drive that when to use and how to use, develop some paper on this, and this review paper came out on this. And basically, base paper is available on the net. You can go and check for it. It will give you some guidelines on how to manage sepsis in a resource poor country or Southeast Asia, some basic guidelines, and maybe helping many of you people to understand and treat sepsis. And this is one of our another publications in the Journal of Critical Care Medicine. This is on extracorporeal blood purification strategy in sepsis and septic shock. This was on extracorporeal blood therapy. The previous publication was sepsis management. This was targeted only on extracorporeal. This is also Dr. Yatin and myself, we published this. This is on extracorporeal therapy. What is the present scenario, how to use it, and what is the future perspective that we go. Both are easily available, free to download. Anyone can go and check it. And this was another retrospective data from Dr. Yatin from Delhi and 100 septic shock patients in India. And he also more or less showed the same data, that requirement of noradrenaline coming down, MAP improving. Also he showed that early use improved outcomes. And in his study, he actually measured most of the cytokines, IL-2, IL-4, IL-6, IL-10. And there was basically all the cytokines he could show a significant reduction when cytosol filter was used. So as I told you, this is a easy to device which can use hemoperfusion as a standalone unit with CRRT, with cardiopulmonary bypass, with ECMO. You can use it with any circuits. Now coming out the Zaffron, another 10 minutes we'll finish it off. I've not even 10 minutes, 6-7 minutes. The Zaffron is the one which has come latest in the market, and a lot of data, people are talking about as it is basically used for 4 to 6 hours, at a maximum 6 hours, not more than that. It is a disposable hemoperfusion cartridge with absorbent material made up of neutral microporous resin with some colloidal coating, and it is only problem it's stored in a very acidic environment. So the priming has to be done very religiously by the technician. So 45 minutes, 30 to 45 minutes the priming time, and even after priming, the pH checked in that was found to be somewhere in the range of 3.3 to 4, which is still acidic by the environment. So there are small chances that the patient may develop coagulopathy with this device, but data is not yet out on that. And generally used for 3 to 5 hours. A comparative in vitro study was conducted for cytosorbents and Jafferon, very recently published, and both showed equivalent reduction in the cytokine levels. However, the data did show that cytosorb achieved it much faster than Jafferon. So the nadir levels of cytokines reached by cytosorb was much earlier than Jafferon. So that's where in a septic shock scenario, obviously you want the things to work faster. So that's where both of the devices removed equivalent amount at the end of therapy, but the rate of removal was faster with cytosorb. And about polymyxin B filter, which all of you may have used it here. It came in a big way from the simple polymyxin coated filters absorbing lipopolysaccharides or endotoxins. So by definition, when you are you're talking of a filter which contains endotoxin binding, so it is simple to be used early into the sepsis part of pathway. If the patient is already in a severe cytokine storm, probably the filter is not going to benefit much. So early initiation of polymyxin filter is what's required, and that is probably one of the reasons why this filter failed in many centers. Initial a lot of data came in, but subsequently when the euphrates data came in, it showed that increased mortality with the use of this filter. However, when they did an sub-analysis of the subgroup of patients, they found patients with endotoxin assay between the group of 0.6 to 0.9 EAA or endotoxin assay, which easily and most good centers are doing it now. EAA subgroup of 0.6 to 0.9 patients did better, mortality outcomes were better. However, when the EAA was more than 0.9, so the mortality was higher. So for using polymyxin, we need an endotoxin assay. The endotoxin assay in the range of 0.6 to 0.9 would be a patient where you could use it. However, being a lipopolysaccharide absorption device, it may not mitigate the cytokine storm as well as the other devices. And the recent surviving sepsis guidelines of 2021, which published, it said that patients, for adults with sepsis or septic shock, we suggest using against polymyxin B. So that is the latest guideline that we have. The surviving sepsis guideline does not promote use of surviving polymyxin B filters right now. The other is Oxiris. Oxiris is basically now trying to jumble up things together. You have a dialysate filter, then on top of that you create multiple layers of polyethylamine, which improves the biocompatibility and also absorbs endotoxin. So, and on top of that, this filter is basically a little thrombogenic, so basically it's coated with heparin. So you have a cytokine filter to start off with, a basic cytokine filter, which is called the AN69 membrane, acrylonitrile 69 membrane, which is now coated with endotoxin coating, endotoxin polyethylamine, endotoxin filter or endotoxin absorption. So you have cytokine removal, endotoxin removal, and then coating of heparin. So ideally you're looking at something which will absorb cytokines. So polymyxin filter and cytosorb Jafferon together, this is the filter. So obviously this is going to be the, going forward, this is going to be the filter that are going to use. Everything works with that. However, the questions are, we don't know by what time to change. The answer is not yet clear. We know for cytosorb 6 to 12 hours, maximum 16 hours. Here we don't know what time it stops to act as a pure cytokine filter and only continues to be as a hemodialyzer machine. Again, it is a CRRT filter ultimately. So do you want to put your patients on CRRT early? Lot of data nowadays out. Early CRRT or early renal perfusion therapies, reperfusion therapies in the ICU has shown worsen outcomes. So we are now going away from early involvement of nephrology. I'm sorry to say that, early initiation of RRT in many patients. So in this filter, once you're using this, you are going to also add CRRT to the patient. So that's another question which is going to be asked. Saturation kinetics of the filter not yet defined by the company. How long it takes to get saturated with the cytokine beads, the fiber, they're not clear on that. And again, they have not come out with wanted substance removal like antibiotics and other things. So based on that, we will have to decide how to use this filter or not. So present guidelines from surviving sepsis guidelines, as I told, it tells polymyxin not to be used. Because of insufficient evidence, it does not make any recommendation to not to use other therapies. So it does not say no to other purification therapies. So 2021 guidelines says don't use polymyxin, but they are open. It is a clinical decision left to the clinician. Other therapies they have not told not to use. It's open based on your clinical experience and data and patient criteria. You could use such devices. In summary, sepsis is a life-threatening organ dysfunction, as we discussed, dysregulated host infection, host response. Overshooting generalized reaction of immune system causes release of various inflammatory mediators, which we identified as called as that cytokine storm. With this leads to organ dysfunction and the increased chance of death. And standard therapy may not ultimately survive such patients. In such cases, cytosorb and other devices, immunomodulation may be the going forward. You have to understand the devices properly, and once you start using, then you will get more and more comfortable with your devices. One good thing about most of the devices, they are not harmful. I mean, if you use it, regularly, you will know thrombogenicity, thrombocytopenia. Only problem is where we lie is antibiotic dosings. Like cytosorb as a list, like if you want, I can share you the list of which antibiotics can be removed. Others don't specifically mention which antibiotics can be removed. So antibiotic is a thing because of septic shock, the antibiotic is cornerstone. So you need to know which antibiotics will be removed and how to replace them. So in cytosorb you have a data, others for data are not yet clear. So based on all these discussions, you will have to select your device. Thank you very much.
Thank you, sir. Thank you for so much elaborative talk. Sir, one question from my side. If there is if IL-6 is not available, when to start these filters like high TLC, high lactate, and other inflammatory mediators like ferritin and D-dimer, can we take them into account for starting these things?
We have not exclusively looked at ferritin because it has too many other confounded variables of ferritin. So ferritin, but yes, as I told you in the presentation, if the patient fulfills the criteria for having hyperinflammation, patient having high fever, is at a marked tachycardic, tachypneic, those patients are easy to identify in the ICU. And then you find rising lactates. That's a very easy case. This patient is in hyperinflammatory syndrome and has a bad prognosis. So that's probably a patient. IL-6 number, very important to say, IL-6 is one of the criteria, not the criteria. If you don't have IL-6, doesn't mean anything. And IL-6, again, I'll tell you, I personally have done a trial, paper on publication on various immunomodulators, small 10 patients, septic shock patients with various immunomodulations, IL-6, IL-10, TNF-alpha, and I did not find any particular trend or any particular signal which one go up when. So number IL-6, 500 has been taken from data, anecdotal data that we have in the circulation. If you don't have IL-6, does not mean that you can't use it. It's only to help you or help your junior doctor in the ICU to, okay, IL-6 is high, so I have evidence, some evidence or nothing more than that.
Okay, sir, thank you.
Thank you, sir, for that excellent talk. I really like that part where you talked about that cytoscore, which is probably the thing to be used and probably practically applicable, increasing NORAD doses, lactate scores and all. I think the key is to start at the right time. Too early, too late is bad. The question, it is open to the house if there are questions.
Studies and so on. There are two randomized control trials. Psychov, which was published in Lancet in COVID-19 serious cytokine storm, Lancet 2021. The mortality in the control group is 19% or 20%, and the mortality in the cytosorb group is 75%. So the mortality is 3.5 times higher with cytosorb in an RCT. And there's another one published in 2017, I can't remember the name of the author, where the 60-day mortality is 44% with cytosorb and 27% in the control. So my concern is small studies, inconclusive evidence, or a signal non-significant. But significant mortality difference in 2 RCTs. What is your take on this? I'm scared to use a device which in RCTs is showing a 3.5 times higher mortality than a control.
Your question is absolutely valid, and why this RCTs failed, one of the major reasons was the initial phase of cytosorb, any of the devices that were, there was no clear guidelines how when to use. They were based on companies, if you go by the data, that's studies which you talk, the 2017 one, I'm exactly not the name, but that was again a 40 patient, not a very large study it was. No, it was a randomized control trial, but actually very small number. Very, very small, 40 patients, I think it was total number. So it was the data or the selection criteria was based on the company guidelines, which were very immature at those days. So the major reason for that failure of the initial study that you talked of was because the selection criteria was too late. So probably the patients, very sick patients were taken in that, and patients did not fulfill criteria. So that's probably one of the reasons could be. Though the control group surprisingly did better in this, so I really don't have an answer why it happened. But the second study, I don't know why it, and that's why I'm waiting for the results of the process study, which has started in Germany. We should get it. Even if one accepts, as you said, one study shows too good to be true. Yeah. This looks too bad to be true. Yeah, that's also correct. Yeah, it's too bad to be true. Correct. Yeah, it's too bad to be true that you can have such a huge difference in the mortality. And that was a 40-patient randomized control trial. Probably actually the publication itself is not worth mentioning. The Cytokine study, yes, that has been recently discussed a lot about Cytokine.
Yeah, thank you, sir. Thank you. It was an excellent talk. It's an excellent talk, and I was impressed with your experience and publication. So in fact, we have also tried using the cytosorb in our maximum patients. Not many, but 4-5 patients, and particularly in transplants and during the COVID period when we had very high inflammatory markers, we have tried to use that. But a transplant, yes, 2 patients we have used and 1 patient we could actually, make patients survive. So we have started early. So that's what our experience is, starting early, and particularly, selecting the patients appropriately is, makes a lot of difference in outcome. The second thing I wanted to ask you is, you said you can use in isolation also. We have used in association with CRRT. So you can use in isolation. So how long we use that? So to my understanding, we can use it for 24 hours and then we have to change the cartridge. And because it was in association with CRRT, we were using continuously. In isolation, how long we can
That's
use?
a very
Because
good
there are a lot
point. Actually,
of complications associated, anticoagulation, the filtration, the replacement and all those things.
Yeah, they're actually part of your question answered such question at 24 hours. I forgot, yeah, that's one important point. The study is randomized. The first study, 2017, was 24 hours. Nowadays, the concept of 24 hours is gone. It is now 12 hours is what? Upper limit is 16 hours. So whether you're using with with a dialysis, with a CRRT or with non-CRRT, 6 to 12, at the end of 6 hours, your mind starts to think. End of 12 hours, you start to really assess whether I need a second filter. Not at 24 hours anymore. That 24 hours concept is gone. All studies before 2020 are at 24 hours. Subsequently, when number has come down, and now people even changing at 6 hours, I feel 6 hours is too early. Saturation kinetics is too early. But yes, if the patient is very critical, you may use a change 6 hours also, because the filter may get completely saturated with the cytokines. But ideal time is 12 to 16 hours is when you start changing the filter. Yes.